Hello, everyone, and welcome to today's research webinar. My name is Erin. I use she, her pronouns, and I'm a learning officer here at EGAL. For any participants who aren't able to see me, I am a white woman with straight dark hair. I'm in front of a blue background and wearing a black headset. But I will be disappearing soon as I am just the moderator for today's session, and we'll be getting to the great facilitators in a moment. Just a few things to go over so everyone is comfortable in the space. So first, you'll have noticed when you arrived that we are recording today's session. This is for internal quality assurance purposes. We just like to remind everyone. And for the safety and comfort of everyone attending, screen recording is not permitted. There will only be a few features to pay attention to today. The first is the chat pod, which I mentioned already. You can decide if you want your message to be sent to everyone or individuals. So if there is an issue with your screen or technology, feel free to send it directly to me or visible to anyone. You can ask questions here, make comments. If something reminds you of another resource, you can share that here as well. And if anything like that is shared that could be useful, I will be grabbing it and putting it in the follow-up email, which is also where you'll be able to find our feedback survey after the session. Another place that you can ask questions is the Q&A pod. Let me back up a second. There should be a ribbon at the top or bottom of your screen. If you can't see it, it may be minimized, but along there, if you swipe your finger across, you should then have it pop up. That is where you will find the chat, the Q&A. The Q&A has the added feature of allowing you to be anonymous. We assume curiosity with questions, but we also want this to be a space where you feel comfortable to ask your questions. So please feel free to use that feature if it makes you more comfortable. We will be saving all the questions until the end, so don't feel like we've skipped you if we haven't gotten to it within 5 minutes. Don't worry, we are saving it. And the last thing to pay attention to is the captions or CC button along that ribbon. Those are turned on for this session and they only affect your screen, so feel free to turn them on or off as is best for you. And lastly, before I pass it over, I will just explain who we are in case you're not familiar with us. So for those of you who don't know us yet, EGAL is Canada's leading organization for 2S LGBTQI people and issues. We improve and save lives through research, education, awareness, and by advocating for human rights and equality in Canada and around the world. Our work helps create societies and systems that reflect the universal truth that all persons are equal and none is other. And with that being said, I will pass it over to Brittany for some more welcoming remarks.
Thank you, Erin. Hi, everyone. My name is Brittany Jakubiak. I am the Director of Research at EGAL Canada. I'm joining today from Abequit or Prince Edward Island. And for a visual description, if you can't see me, I am wearing glasses. I have a striped shirt and a black sweater on. I have blue glasses and short dark hair. I'd like to thank you all for attending the first of our Research Highlights webinars for 2025, of which there are 4 this year. This webinar series is intended to showcase 4 research projects and partnerships focused on topics such as aging, healthcare, GBV, and housing. And we hope you'll consider joining the other 3 webinars happening in April, August, and September, and I will put the link in the chat where you can register. Today, I have the absolute pleasure of introducing our 2 speakers, Hannah Kia and K.A. Kenny, who will speak to you about the Aging with Affirmation project. K.A. is a PhD student at UBC whose research focuses on social work practice in healthcare with trans and gender diverse youth. And Hannah is an associate professor at UBC in the School of Social Work and is the principal investigator for the Aging with Affirmation project. And without further ado, I will pass things over to K.A. and Hannah for their presentation. Thank you, everyone.
Thank you so much for the introduction, Brittany and Erin. My name is Hannah, and I am very proud to be representing a team of researchers from across Canada that sought to study the healthcare and social service experiences and needs of trans and gender diverse older adults in Canada. Just wanted to very warmly welcome everyone to the webinar. And without further ado, I want to pass the baton over to my co-presenter, Kay. Thanks so much.
Thank you, Hannah. Thank you, Erin and Brittany. And thank you, everyone, for joining us today. I go by Kay, Kayla, or KA. My pronouns are they and them, or any pronouns are okay by me. Like Hannah, I am joining here from the ancestral occupied territory of the Hokumenum-speaking Musqueam people. I am a white settler. I'm a current doctoral student at the University of British Columbia, where I am co-supervised by Hannah. Before coming to UBC, I practiced as a clinical social worker in primary care with a focus on offering affirming care for patients of all genders.
And just a very quick introduction to myself. My name is Hannah Kia. My pronouns are she and her. I'm an associate prof at the UBC School of Social Work, and I'm actually joining you today from the traditional and occupied territory of the Hunkaminam-speaking Musqueam people, which we know as the UBC Vancouver campus. Thanks so much.
We wish to begin today by recognizing the Indigenous people on whose territory the University of British Columbia, as well as EGAL, is situated. So EGAL is situated on the land of the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. The University of British Columbia is located on the traditional, ancestral, and occupied territory of the Hokumenum-speaking Musqueam people. The Indigenous peoples of Turtle Island have always been and will always be stewards of this land. We thank them for the opportunity to be here today. The study of focus in this presentation was led by a team of researchers from across Canada with different relationships to trans and gender diverse communities, or TGD communities, including those of TGD older adults. And this research was proudly conducted in partnership with EGAL. Thank you, EGAL. We'll bridge into our presentation with the words of a participant in this study. The following was shared in a focus group by a Métis Two-Spirit trans woman in her mid-60s. And in that parade in 1972, I got arrested for wearing a dress, and they charged me with disturbing the peace because I wore a dress. And my experience with social services from day one became a living nightmare. I didn't want to see those social workers. I didn't want to see that child advocacy worker. I didn't want to see any more police officers. It damaged me by being arrested. She expanded on this, making the link to her current advocacy explicit. These experiences not only set up the expectations for me, but it also set up my understanding of what I need to do in society. That I needed to be that advocate, that I needed to be that voice. The unfortunate part is that there's still a lot of stigma, but those complexities really kind of shaped me into the person that I needed to be to do the work that I do. We're starting here because her words speak to the harms older TGD people have long endured within systems of care meant to have a mandate to help, a mandate to support well-being. This participant also spoke to how her lived experiences were a catalyst for advocacy that continues to be necessary given the continued persistence of harm within TGD older adults' experiences of health and social care. This brings us to the focus of our webinar today. Throughout this presentation, we'll share what we learned from this research study, which was designed to bridge the insights of TGD older adults and allies into actionable insights that can be drawn on to improve healthcare and social services for this community. We'll offer an overview of the study's design and discuss the recommendations that have emerged from the study's findings that can guide practice, advocacy, and policy in service of better meeting the needs of aging TGD people. First, some context. TGD older adults today have lived through decades where being transgender is not only stigmatized, pathologized, but actively criminalized. Many face discrimination from employers, healthcare providers, social services. Some were arrested or denied necessary medical care for living in their gender. Enduring this hostility is linked to the health disparities facing this population present day. These experiences shape how many TGD older adults approach services today. There is a widespread distrust, which is not incidental. It's a direct consequence of decades of harm. Further, the barriers that TGD older adults face in healthcare and social services today are not isolated. They stem from overlapping structures of oppression, including transphobia, cisnormativity, aging, racism, and more, that have shaped discrimination within health and social care, as well as in state-run institutions of child welfare and law enforcement. These have long impacted access to care through the criminalization of gender nonconformity and punitive surveillance that has disrupted access to stable housing, employment, and medical care. These forces are interconnected and in concert have systematically excluded and marginalized TGD people in care settings, leaving aging TGD individuals disproportionately vulnerable to discrimination and inadequate care over their lifetimes. Throughout this, we know that TGD older adults have found one another and created spaces of care and support within community beyond the systems of care where they have long faced exclusion. Research has contributed to an evidence base that demonstrates that social support among 2S LGBTQI people is a critical safety net, bolstering TGD older adults as they resist and counter marginalization. Yet, there are still gaps in research. Many studies have focused on 2S LGBTQ communities more broadly, leaving much to be known about the specific needs and concerns of people who are at the intersection of being trans and aging. Additionally, research of the Canadian-specific context of health and social care is growing, but still early in its emergence. To contribute to this expanding research, exploring the specific needs of TGD older adults in Canada, this study drew on interpretive description. This method is particularly useful in applied health and social research because it prioritizes generating real-world applications for practice. A series of focus groups were facilitated, bringing together TGD older adults in one set of conversations and service providers and advocates in another. The questions raised during these focus groups were designed to identify gaps in services, challenges faced when seeking care, and what changes are needed to create more affirming and accessible systems of care. After transcribing transcripts from each focus group, findings were analyzed through a lens of critical gerontology, which helped situate individual experiences within structural contexts, historically and ongoing present day. Finally, as part of our effort to make sure this research was grounded in the lived expertise of TGD older adults, we used a process called member checking. This involved 2 participants who were both TGD older adults and service providers themselves, reviewing the findings for accuracy and relevance. So who were the rest of the participants in this study? There were 21 in total. You can see some of the demographics here on this slide. Of note, since some participants expressed their identity using multiple terms for gender, race, and/or ethnicity, some of the numbers here add up to more than the numbers of participants. But as you can see, 10 older adults and 11 service providers took part in focus groups. TGD older adults in the study were between the ages of 51 and 73. The majority located themselves as trans women and/or used feminine pronouns. 2 were two-spirit, 1 non-binary, and 1 participant described himself as a man of trans experience. Our sample was predominantly white and included 2 participants who described themselves as Métis and 1 who described themselves as South Asian. TGD older adult participants were also invited to share whether they identify as a person with a disability, which the majority of 8 did affirm. Among practitioners and community advocates, the ages ranged from 23 to 73. Roles included care providers, support workers, activists, counselors, and volunteers. From this research, we have 5 findings to share. Historical context and experiences of structural oppression. Visible and invisible precarity at the nexus of transness and older age. Intersectional expressions of contemporary state and institutionally sanctioned oppression. Resistance of TGD older adults and their allies across service settings. And lastly, closing current gaps through ground-up activities to build space for TGD older adults. To help illustrate our first finding, historical context and experiences of structural oppression, we'd like to share the words of a Latina trans woman who was a healthcare provider in her early 70s. She spoke to the impacts of decades of institutionalized discrimination on an entire generation of TGD older adults. She shared, "The baby boomer generation, we're the ones that straddled the lines between being pathologized and not being pathologized, between being criminalized and not being criminalized for our sexual orientation or gender identity. So there's a lot of internalized oppression and repression. We're just beginning to appreciate the impact of that kind of physical, emotionally draining cognitive process of always being careful, being ultra vigilant, not being able to express your identity, not being able to approach a partner in public." Many participants described a lifetime of facing exclusion, harm, or outright denial in seeking health and social care. These experiences shape how older TGD people anticipate and engage with care settings today, and for many, have eroded their trust in these institutions entirely. While this can push many to avoid or delay seeking care, participants did describe actively seeking out affirming care providers whenever possible. Our next finding is invisibility, visibility, and precarity at the nexus of transness and older age. The following account is from a white trans woman in her early 50s. In a focus group, she shared, "I ended up fired by my family doctor, who was a devout religious person. I had been receiving, in connection with that family practice, counseling. And when they kind of boot you out for their own reasons, you lose access to everything. So I think it's imperative to recognize that certain aspects of your care can be quite tied to the medical aspect. And if you find that somebody is not comfortable, you lose all of that." This participant's account speaks to a core theme in our findings: precarity. We use the term precarity to describe the heightened vulnerability that TGD older adults face due to systemic exclusion and barriers to reliable supports. Whether TGD older adults are perceived as visible or rendered invisible in care encounters, both can create barriers, like the direct discrimination described in the participant's account, or having needs that go unmet, ignored, dismissed, which can contribute to inadequate or inappropriate care. TGD older adults and their allies have long pushed back and will continue to advocate for better policies and practices. We'll describe this resistance further in a finding to come. However, as our study found, despite decades of activism, systems of health and social care continue to lack affirming, adequate resources for aging TGD people. This problem is compounded by the persistence of cisnormativity and the norms that this structure reinforces around family. There's an assumption that all people's aging experiences follow a pattern, wherein younger nuclear family members will care for generations ahead as they age. However, not all TGD older adults in this study had access to the same kin-based supports that can assist people to age at home if they wish to. As a result, aging TGD people may be even more likely to rely on formal care systems, such as long-term care or hospice care, which can in turn further expose them to the adversities we've discussed so far. Our third finding is of intersectional expressions of contemporary state and institutionally sanctioned depression. The following participant, a non-binary South Asian service provider in their late 30s, drew on a metaphor of the canary in the coal mine to speak to how systemic failures in health and social care do not impact all groups equally. Those who are multiply marginalized, including racialized, disabled, and low-income TGD older adults, face compounded risk. In their own words, it is the fact that the healthcare system is overburdened and bursting at the seams. But it's also the fact that these individuals are more vulnerable and more marginalized to begin with. So whatever shortcomings the system has, even for the more privileged among us, affect the vulnerable and marginalized folks disproportionately. They're sort of the canaries in the coal mine in that sense. Our findings demonstrate that inequities in healthcare and social services cannot be understood in isolation. They must be examined through an intersectional lens. State policies, particularly service rationing and funding cuts, contribute to strains on healthcare and social services for all people seeking care, and those who are multiply marginalized are likely to be burdened with the greatest impacts of these strains. This is compounded by policies that impose stringent eligibility criteria, often as a direct result of these austerity-driven cutbacks. These policies, whether intentional or not, restrict access to essential services like subsidized housing and prioritize individuals who are white, able-bodied, and who do not report mental health conditions. As a result, older TGD people who do not fit into these narrow criteria face heightened precarity and exclusion from these vital support systems. Our next finding, resistance of TGD older adults and their allies across service settings, is spoken to by the following participant, a white man of trans experience in his late 50s. He described navigating care as the first openly trans client in his trauma therapy program as follows. I transitioned with this program, but I just had to change. First, I made them start calling me he and whatever. I was like, I'm doing this trans thing. And they never asked me how I identified. They just didn't until I had to be like, call me he. I was there first. His experience highlights a broader pattern found in this study. Many TGD older adults have had to carve out their own spaces in health and social services, often in the absence of existing precedents to guide them. Participants emphasized that demands for competent, respectful, and accessible care for TGD older adults are not new. They've been voiced for decades. While navigating systems that remain entrenched in hostility, resistance from aging TGD people has taken multiple forms. from individual acts of self-advocacy, like demanding use of correct names and pronouns, or confronting discriminatory practices within care settings, to taking forms of collective organizing, such as the creation of community-led initiatives and advocacy groups. Again, many TGD older adults in the study challenged trans antagonistic systems with little precedent to rely on. And for some, facing transphobia within care settings became a turning point that brought them to activism, advocacy and activism. They've become educators, advocates, and leaders in improving services to ensure that their own and future generations of TGD people receive the affirming and equitable services that are deserved. Our final finding, closing current gaps, ground-up activities to build space for TGD older adults, is illustrated through the powerful support described by a participant, a trans woman in her 30s. She shared, "At the peer-led program, they listen, first of all, and they try to really help. They're like part of the family right now. It's actually, the community center is sort of like a second home to me. I'm kind of learning slowly and being given the chance to, tell them what's been really going on with me. And they sit and they listen. And they have little strategy projects. It's not like they would brush you away and just say, oh, come back next week. We'll look after you." Our final finding of the study highlights that community-driven initiatives are needed to address the problems that continue to persist in health and social care. Engaging TGD older adults in designing, delivering, and governing services for their communities is not just beneficial, it is essential to advancing long overdue systemic changes. Many participants expressed that while mainstream services often fail to meet their needs, peer-led initiatives by and for TGD people have become a crucial alternative. These programs offer spaces where individuals can access support and belonging, and as we'll discuss in our recommendations, it's of the utmost importance to sustain and expand these programs so that TGD older adults, including those in rural regions, can access affirming support. Before heading into recommendations for providers, advocates, and policymakers, we want to highlight 3 key takeaways that summarize and reinforce the findings we've explored throughout this presentation so far. First, this study has added to the empirical evidence base that decades of transphobia and systemic inequities in healthcare and social services have deeply impacted TGD older adults. Many have experienced discrimination, inadequate services, outright denials of care, which has contributed to widespread mistrust in institutions. These barriers continue to make it difficult for TGD older adults to access essential care as they age, whether that's gender-affirming medical care, aging care, safe housing, or further services. Next, to create systems that truly work for TGD older adults, we need to meaningfully involve them in shaping services. This means consulting with TGD older adults when developing policies, ensuring that initiatives by and for aging TGD people are accessible, and securing sustainable funding for these community-driven resources. Lastly, it is crucial to work towards these needed changes from an intersectional lens. TGD older adults are not a monolithic group. Their experiences can be shaped by additional factors, including ethnicity, disability, socioeconomic status, and more. And in relation, structures of racism, ableism, poverty, and further forms of marginalization. Effective care must recognize and attend to these intersections and actively work towards bringing aging TGD people who are racialized, newcomers, disabled, and/or experiencing poverty to the center of policy and practice changes. Without an intersectional approach, we risk leaving behind those who are exposed to systemic oppression on these multiple fronts. So how can we work towards enacting these findings? We have specific recommendations we'd like to offer policymakers, organizers, and care providers. We'll start here with providers, who hold power to directly impact the experiences of TGD older adults as they access health and social care. This section highlights two key areas of focus: building trust in health and social care, and connecting TGD older adults to affirming resources. Firstly, our findings add to a considerable body of knowledge that tells us that TGD older adults may approach health and social services with caution, often due to experiences of harm, discrimination, or inadequate care. Practitioners on the front lines have a crucial role in working towards building aging TGD people's trust in these settings where they have long been subjected to harm. Trust takes time. For many TGD older adults, including those who have faced decades of oppression within health and social care, a single positive interaction won't undo years of harm. But a commitment to long-term affirming care relationships can contribute to shifts in TGD older adults' experiences of care over time. This might look like prioritizing respect and actively working to not be defensive towards expressions of mistrust. By recognizing the reality of the ongoing history of oppression faced by aging TGD people within systems of care, we have an opportunity to validate this lack of trust, working slowly towards repair, rather than taking mistrust personally as providers. Approaching concerns with an openness and a willingness to learn from the experiences of TGD older adults can be a small step towards rebuilding safety in these environments. Our second recommendation for providers is offering TGD older adults links to resources that are affirming of gender, aging, and further intersections. Having a vetted, up-to-date list of service providers can reduce the burden on TGD older adults in navigating systems that too often exclude them. This might include seeking out TGD-focused initiatives within organizations that serve seniors, as well as seeking out initiatives for TGD older adults within 2S LGBTQI-focused organizations. Additionally, facilitating referrals to peer-led spaces by and for TGD older adults can provide vital sources of support. In some places, including rural geographies, programming led by TGD people can be sparse. This can be even more true when seeking to connect aging TGD people with peers who are also racialized, experiencing mental health conditions, and/or other further specific intersections. We'll share our recommendations for advocates and policymakers to work towards closing these gaps in subsequent slides. In light of this challenge, virtual peer-led spaces, including those that are online, or even those that are phone-based connections, were identified by participants as a meaningful alternative when accessible. Lastly, care providers can collaborate with aging TGD people who are in search of accessible housing to help make it possible to stay in their homes as they age. Taking an active role in connecting TGD older adults to the resources needed to age in place, whether through direct referrals, advocacy within housing systems, or coordination of home-based supports, can help bridge this critical gap in care. Advocates and organizers are essential in driving these needed changes. Two of our key recommendations are to call for training that is designed and delivered by TGD older adults, and capacity building for services that are created by and for TGD people. In regards to the former, our findings highlight that TGD older adults play a crucial role as educators. This means partnering with aging TGD people in developing, implementing, and evaluating programs, as well as linking them to opportunities so that TGD older adults can offer their direct insights to policymakers, care providers, and other decision makers. When first-hand accounts reach these key decision makers, it can be a powerful catalyst for action. In working alongside aging TGD people in these ways, it is vital to recognize their expertise through fair and meaningful compensation. To our second recommendation of advocating and organizing for care by and for aging TGD people, we recommend bringing a focus to securing funding initiatives that directly benefit, or rather funding for initiatives that directly benefit TGD older adults. This means calling on governments to increase financial support for essential services, including housing assistance and peer-led networks. Additionally, we recommend advocating for organizations to comprehensively integrate peer-led programming into health and social care, recognizing it as a core component of this care, and in particular, aging care. Finally, long-term grant funding is essential for peer-led programming. These spaces offer invaluable support, yet they often remain underfunded and vulnerable to financial instability. There is also a need for funding opportunities that can sustain new initiatives that address emerging community needs. Finally, at the levels of policy and leadership, we recommend community-led policy changes that are guided by the lived experiences of TGD older adults. In addition to equitable measures ensuring non-discrimination protections are in place and actively upheld, the availability of mechanisms for recipients of care to provide feedback is also vital. TGD older adults need accessible ways to provide input on the services they receive, and those insights should directly shape policy and practice improvements. Further, recognizing many teachings can only come from aging TGD people themselves, this recommendation includes ensuring care providers are able to receive training that has been developed alongside TGD older adults. Next, there's a need to invest in aging-in-place resources across intersections. Our research builds on existing studies that highlight aging in place as a clear priority for many older adults. And TGD individuals face heightened precarity, both in their ability to age in place and the challenges they encounter when this option is unavailable to them. For aging in place to be more viable for more aging TGD people, we need targeted investments in home-based and community care services that acknowledge the intersecting barriers to safe, affordable housing. Additionally, subsidized housing, long-term care, home-based support services must all be designed with respect for gender diversity, ensuring that TGD older adults are not forced into unsafe environments simply because affirming care options are limited. Last but not least, aging TGD people must be represented in the governance of their care. When TGD older adults have a seat at the table, in advisory boards, leadership roles, and decision-making bodies within healthcare and social services organizations, policies and programs are better positioned to become more responsive to their needs. The knowledges of TGD older adults are essential to improving the systems of care that serve them. To conclude, the experiences shared by TGD older adults and allies in this study have offered us an opportunity to better understand how we can work together to create the high-quality, affirming health and social care experiences that aging TGD people deserve. TGD older adults are experts in their own aging experiences, and their knowledges are necessary in transforming systems of health and social care to honor the dignity and well-being of all older adults. Each of us has a role to play in making healthcare and social services more affirming and accessible. TGD service users, patients, and allies have long led the way. Whether you're an advocate, a social worker, a healthcare provider, policymaker, leading an organization, or hold another role, we can join this ongoing effort by pushing for TGD older adults to be centered in decision-making at all levels of care that serve them. Thank you for taking the time today to be part of this, for learning about this study, our finding, and our recommendations. We'll share references on the next slide, but we'll transition over to a Q&A discussion now. And if you have any questions about this study or the accompanying community report, Hanakia or myself would be happy to offer our answers. Thank you again.
Thank you so much, KA and Hannah. I would encourage folks in the audience that we have to post any questions you have in the Q&A box, which I'll keep an eye on. And I want to thank you both again for just a really wonderful presentation and a really wonderful community report as well, which is very accessible. And I hope that many individuals read that and take some action. Perhaps for while we wait for questions to come in, I'll ask a question to get us kicked off here. When you were conducting this study, was there one finding or one thing that really surprised you, maybe in the data or during your analysis that you'd want to share with folks on the call?
Thank you so much, Brittany. I really appreciate this question. And I'll say that, we headed into the study with initially a very present focus. We wanted to get basically actionable recommendations on what needed to be done in the contemporary landscape of healthcare and social services. And when we got to focus groups, we noticed that participants wanted foremost to talk about history. History being so influential in shaping the contemporary landscape of services. And so this was a pivot in both data collection and analysis to really pay attention to historical context. It was something that I was already primed to do, given some of the literature I had been exposed to earlier, but it was still surprising how prominently it stood out in the first couple of focus groups. And I'm so appreciative of that because I think the historical focus really enriched and rounded out our findings.
Thank you very much. Still waiting for questions. I have a second one. I noticed that we have an incredibly diverse audience. I noticed folks from pride organizations, professors, researchers, and students, community members, and community organizations all in our audience here today, which is amazing to see. And a lot of information was presented, a lot of wonderful information was presented. From your both perspective, if there was one thing folks could take away today and or one action someone could take based on your research and your findings, what would that be?
I think, and I'd love to hear Kay's thoughts on this as well. For me, what really stands out is finding meaningful ways of engaging in folks with lived experience. For our study, really, one thing we were really thankful for was incorporating two individuals who were both TGD older adults, as well as community advocates and had experience as service providers, really hold us accountable in our analysis and gave us ideas about how to refine some of our conceptualization of the data so that our work would be accountable to community and it would authentically represent their interests. And I think this is the type of engagement that anyone can incorporate, in their work as a researcher or perhaps policymaker, is just thinking about ways of incorporating lived experience as actual insight to be honored. I don't know, Kay, do you have anything to add to this?
Yeah, my initial thought was very much so along similar lines. And so well put, Hannah. And thank you, Brittany, for the question.
Mm.
It stands out to me that across each of our recommendations, whether it's for providers, advocates, policymakers, that it is working where you are to find a way to partner with aging TGD people to learn from them. And I'm humbled by how generous that is, that there is still a willingness and a hunger to uh, contribute to making our formal systems of health and social care better. I think that's a
Mm.
remarkable generosity in the context of this history. And so, how can we uh, partner with humility to make spaces where, whether it's in direct care interactions or advocacy efforts or in implementing new policies, to ensure that some of the knowledge that TGD older adults are so generously willing to share is making its way into these spaces?
Mm.
Um, I hope you don't mind if I interrupt Brittany, but I have my own question I'm curious about. Um, like I said before we started, this is all new information to me, so this is very interesting. Thank you both so much. But as someone who sort of works outside of research, I focus very much on like the tangible human side of things. And I was curious, you talk to so many people with lived experience, you have your own lived experience, of course. With all of those things around you, was there anything that like very much surprised you and was outside of the things that you had heard about before? Or is there anything that stood out that you think is worth repeating as like a main takeaway?
Yeah, thank you so much, Erin. Great question. I'm gonna fall back on the answer I gave earlier around historical context, um, and really the importance of bringing what we think of normatively as the past into the present, to really think about how that shapes contemporary experiences. And, beyond that, really thinking about peer-led programming and the strengths that it can offer a community. Just in full transparency, the study I did before this one was centered around peer support experiences in trans and gender diverse communities. And again, what stood out was how community steps in to address significant gaps in service provision, recognizing that unfortunately, formal systems of care often lack the knowledge, direction, expertise to actually meaningfully respond to needs that surface in community. And often peers step in where those gaps are particularly prominent. I will say something that's really, really critical is the need to create structures to sustain this work with equitable compensation, because often this labor is sort of taken for granted. And unfortunately, it does tend to get commodified within organizations that are very well-meaning. And so just making sure that lived experience is treated as real expertise and that it's sustained long-term beyond stopgap measures. I would say that those are probably a few thoughts I have to share.
I mean, that was excellent. Thank you so much. I can actually see Brittany typing in the back here another question that actually related very closely. Did you want to ask that, Brittany?
Yeah, I think it's building a little bit on what Hannah saying about peer-based supports, but there is a question in the Q&A about any initiatives that have been directed towards supporting TGD older adults who do lack kin-based care options.
Thank you so much. That's a really great question. So I'm not aware of any formal initiatives that are sort of organized around that mandate. But when we looked at our data, and certainly in a lot of adjacent studies and other jurisdictions outside of Canada, what stands out is that a lot of trans and gender diverse older adults organically build their own families of choice. And that, networks of care can be very, very rich depending on opportunities that folks may have had for connection. So what that sort of tells me is something about how important it is for service providers to make connections between trans older adults who may otherwise not come into each other's lives. We do really play a key role in that, and creating structures that allow people to come together and organize.
Mm, that's lovely. So I don't see any other questions. I'll ask one more, and if another comes in, we might have time to address it. Perhaps the last question I have is an observation I have about this study is that it's very action oriented, and that you folks are certainly eager for individuals to understand the findings and to take action in their respective areas. Do you have any other advice for researchers in doing action oriented research?
Great question. Um, I will say that it's that the best advice I have for researchers is just to stay connected to the ground level, and pay attention to conversations that are happening without our involvement. As a trans woman myself, I'm often in virtual and in some cases in-person community spaces where I really try and take direction from what I hear, and then sort
Mm,
of revisit that in terms of the literature and put those two things in conversation with one another, because I think the literature can go stale really, really quickly, and we need to pay attention to a conversation that can be very dynamic, depending on how the community shifts and where it sees its own priorities.
mm. That's perfect. There's one question in the Q&A. We'll take this, I think, as our last question. So the question reads, could you talk more about the pros and cons associated with the choice to remain invisible or to make oneself visible as a TGD person?
Oh my gosh, what an excellent question. And I'd be curious to hear if Kay has anything to add to this. But again, and I say this as somebody who claims positionality as a trans woman quite visibly in my work. The beauty of doing this work as a visible trans person is that, relationships can come a lot easier. We're able to build trust in a way that I think would be difficult to do for a lot of cis researchers. On the flip side, uh, you know, this also means that I'm held very much accountable, and validly so, in
Mm,
terms of actually addressing community interests and making sure that those are prioritized. I will say that it does sort of increase a level of pressure or accountability that again is totally understandable and well warranted. Um, One of the risks in being visible is that, of course, the work isn't taken as seriously because there is so-called bias, surrounding
mm,
it. And, that is an assumption that I often push back against quite firmly, because all research is informed by researcher bias. It's impossible to treat questions in the social sciences from a position of total neutrality.
mm,
But that is sort of a stereotype that follows you if you are visible in this space. And in terms of, the difficulties of invisibility, a lot of the time you might do this work and really feel like there's so much more that could be accomplished in terms of building safety and trust, and you may feel compromised. And yet, that is a measure that a lot of researchers might need to take for issues of safety. Like, there are very valid reasons for remaining invisible in this space. Um, some of the benefits of doing this work invisibly is that I think, ultimately folks might read you as being cis and therefore being more credible. Unfortunately, again, this is an assumption that I push back really hard against, but it is something that often is taken up in discourse.
mm.
I don't know, Kay, do you have anything to add to this answer?
Yeah, I do want to highlight the point that you made about visibility and the potential for connection that can follow. And being someone who is openly non-binary, there are relationships that I've been able to make as a researcher, but just also in the rest of my life that have emerged because of that visibility or because of other people's visibility that are precious. But I also want to take a moment to affirm any uh, any choices um, to trend towards that invisibility in any settings at any time, that it's not an all or nothing choice. And this is something that I've learned from friends, loved ones, participants, and the studies that I've collaborated with you on, Hannah, and that you can deeply know yourself, be authentically yourself, honestly and truly yourself, and choose to make an effort towards invisibility in your gender or other aspects of identity. And there are so many valid reasons people might do that historically and currently. And that doesn't make you any less yourself.
Lovely. Well, thank you both for spending your afternoon with me and morning for folks in BC. And thanks to all of the attendees for being here today. This was a really, really lovely presentation. I encourage everyone to check out your community report and sign up for future webinars if you're so interested. But thanks again, Hannah and Kay. This has been lovely, and I hope you both have a wonderful rest of your day.
Thank you so much for having us. This was a wonderful opportunity. And thank you, everyone, for attending. It was really, really great connecting with you all.
Thank you, thank you, thank you, everyone.
Amazing.